since the beginning or middle of March, we've had to respond to the COVID-19 pandemic in terms of how we not only diagnose and treat patients with breast cancer, but how we follow up them in the clinic as well. In terms of diagnosing the disease, we're still be able to see and do mammographic imaging and biopsy on patients with suspected cancer. But what has changed is that the screening program was put on hold. So a lot of the screen detected cancers, which diagnose very small, early, impalpable tumors, that has halted until the peak of the pandemic has passed. So we expect we're then going to get a surge of new cancers coming through, possibly slightly later diagnosed than they would have been otherwise. So we have seen a reduction in the number of new diagnoses because of this. I think there's also been some anxiety and fear of patients who have symptoms in coming to hospital, particularly if it's a big general hospital that is looking after coronavirus cases. So that has probably been another reason why we've seen fewer new breast cancer cases come through. As far as treatment is concerned, surgery had to be reorganized for a lot of patients because the theatres and the anaesthetic staff and the intensive care units were being prioritized for patients with coronavirus. So in London, I work at the Royal Marsden Hospital, which is a cancer centre. We haven't got an acute emergency room, so we have acted as a cancer hub to direct surgery for London patients. And we have worked with the private sector to take capacity from private hospitals to release theatres and anaesthetic space to allow NHS cancer operations to go ahead. And that's been a very successful model, so that patients who needed cancer operations, including breast cancer, have been able to go ahead and get those operations. Now, within that, there has been some prioritization that has been done. So, for example, patients who are postmenopausal, have a small ER-positive breast cancer, can safely be put on endocrine treatment, and that can start to shrink and treat the tumor, and their surgery can be delayed by a number of months. Patients with, perhaps younger patients with large triple-negative breast cancers might initially go through chemotherapy to downstage their tumor before surgery. So prioritizations have changed from a surgical perspective. Likewise, for the treatments, the chemotherapy treatments that we give, we've looked at whether or not some can be modified, either deferred, but also we've used growth factors more liberally to keep blood counts up and reduce the risk of neutropenia through chemotherapy, which is one of the primary concerns. So there have been major changes to how we deliver cancer treatment to reduce risk and reduce the footfall of patients in hospitals. The other example is radiotherapy treatments have been shortened because of a large trial called Fast Forward that showed you can get down to now 5 days of treatment. So we've accelerated a lot of change that we were going to probably introduce because of the virus pandemic. But the overall message is that diagnosis and treatment of cancer has and should continue. One of the things we've learned in the COVID-19 pandemic is that we have changed the way we communicate with our patients, probably for the better. We do telephone clinics now. So this morning I've done a telephone clinic of a dozen patients on chemotherapy. I can access all their results, their prescribing of chemotherapy, order their scans, see their blood results, all remotely. And speak to the patient, and they have appreciated not having to hang around hospital and waiting rooms and be seen in a more timely and efficient manner. I think there are limitations. Patients that perhaps do not have such good news from results of scans benefit much more from a face-to-face consultation and support of a clinical nurse specialist that will be with you in that consultation. So we've missed that ability in certain clinical scenarios. For example, also seeing new patients and discussing their diagnosis and treatment plan. But for patients that you know well, that are on regular treatments, a quick follow-up telephone conversation or a video link, and doing all of the treatment remotely in terms of authorizing and checking it can significantly reduce the footfall of patients in hospital And they have really appreciated that change, as have clinicians. So it is going to be part of the new normal. Just like we prioritized surgery dependent on a number of clinical factors, we've done exactly the same with systemic treatments for metastatic disease. So the UK breast cancer group coordinated guidelines which went around the country to prioritize systemic anti-cancer therapies and make sure that the most important treatments were prioritized, and perhaps fourth or fifth line palliative chemotherapies where there was a real limited benefit and a greater risk if patients became unwell with coronavirus during chemotherapy. That discussion about the benefit or not of treatment was now weighted in a very different manner. We've also managed to offload a lot of treatment away from the hospital. For example, CDK4/6 inhibitors, which are the standard of care for metastatic ER-positive disease. We have couriered those medicines to patients. They may have blood tests done locally. They don't have to attend the hospital. Patients who were on subcutaneous treatments such as Herceptin or denosumab, we've taught them how to administer the injections themselves. So we prepared a video, showed them how to do the injections, we courier the drug to the patient. So these treatments that don't require intensive monitoring as some chemotherapy regimens, we've learned a new way to deliver the treatments so that can continue. And again, that released about 40% capacity in our medical day units, which were at the height of the pandemic, when we were losing staff to coronavirus and sickness, allowed us to continue business as best we can. So we've changed the way we give the treatment. We also give quite a lot now through our mobile chemo unit that goes out to patients in the locality. And we've upped the activity in that distribution of chemotherapy. So we've adapted, we've changed, and we've allowed treatment to continue. So I think in terms of early breast cancer, after a diagnosis and an operation to remove the cancer, we normally have an MDT that determines the further ongoing primary treatment, the indications for chemotherapy, surgery, etc., for radiotherapy, etc. Now, those MDTs now occur by Zoom, so everyone can join the MDT but not be physically present in the room, so that is different. Again, our relative indications for chemotherapy may change now. So if it is relatively borderline degree of benefit, I've certainly had 2 patients where we have then come off the fence and decided not to proceed with chemotherapy because of worries that patients have about becoming ill during their treatment and developing problems or picking up the virus infection. We have had patients develop COVID-19 on systemic treatments, including chemotherapy, and on CDK4/6 inhibitors. They don't particularly appear to be more ill than any other groups of patients, and all the patients we've had have luckily recovered well. So again, we have still advised the treatment for the cancer based on the cancer and its merits, but the balance of treatment for chemotherapy in certain node-negative ER-positive situations where there might be an oncotype intermediate score, we might be coming much more in favor of not giving any chemotherapy. Radiotherapy schedules have also shortened because of the fast-forward data, but again, treatment is still given, but in an adapted way. It's very important to recognize that for COVID-19, there are other predisposing risk factors that increase the likelihood of severe morbidity and/or mortality. That can include co-morbidities such as diabetes, hypertension, increasing age, particularly more in men, interestingly, than in women. There's debate about whether the Black African minority ethnic group have an increased risk as well. And that may be related to some genetic predisposition to how they handle the virus. Elderly patients are certainly a risk, and those with underlying lung conditions. So these patients were all sent NHS England letters at the beginning of the pandemic, recommending them to self-isolate for 3 months, essentially 12 weeks till the middle or end of June. We sent all those letters out for patients deemed to be at risk, including those with lung morbidity and those on systemic therapies, and provided patients follow those guidelines, they can still have their hospital treatment delivered through the ways I've discussed. But we have to be extra careful in those with other comorbidities or the elderly. But it's not to say that they can't have their cancer treatment. We just need to be more cautious. I think this is one of the real issues that we didn't appreciate at the outset, that it would essentially halt and stop clinical trial recruitment. So very quickly, all trials were put on hold. Staff who were involved in clinical trials were either worked at home or furloughed. Patients on trials were allowed to continue, but we were not allowed to open up new trials or go through the setup process. Now, luckily, that has changed now. In the last week or so, we've started to open our trials up again. We're working with sponsors to see that that can occur. Patients on trials, again, we've delivered new ways of working so that the monitoring of the trial can be done remotely, that the visits can be changed so that we can still allow the trial to collect the data that's important for the endpoint of the trial. But there will be a hiatus in recruitment to some key studies. But I think in the end, that hiatus will only be the order of a few months. So for some trials, it might make a difference. For others, it won't. But now that we are over the worst of the virus pandemic, clinical research is starting to get active again. It's also yielded new research. We've joined the national COVID-19 trials to track and understand the patients who get coronavirus, how they manage if they have concurrently got cancer. And for example, the CDK4/6 data where you have low levels of immunosuppression, we want to understand whether that really did or did not put patients at risk, and that's going to be a national effort to collect the data on those patients to see whether that is a risk or not. So new research has come from the pandemic. Old research has been delayed, but is now getting up and running again. The way we operate in hospitals is going to be changed possibly forever now in terms of how we deliver treatment. Social distancing is clearly important until we have a vaccine to eradicate the risk in the community. So as hospitals reopen, waiting areas are going to be substantially reduced. Slot times for scans, perspex screens between treatment areas, all of these measures are being brought in at our hospital as we open up for a greater capacity. I think telemedicine, telephone clinics are here to stay, and the way we do clinics will be different. We'll have some face-to-face, some telephone-based services. I think in terms of will there be a surge of new cancer and delayed diagnosis, I'm afraid I think there possibly will. I think the government public health message is, if you're worried, hospitals are open for business, please do come and present yourself. But that still doesn't stop some inherent fear and anxiety in patients who think, well, in actual fact, I'll wait another month and see if the situation is a little bit better. So I don't think it will all be a rush at once. I think there'll be a steady trickle. But I expect when we look back at 2020, we'll see a dip in new cancer diagnoses during the spring and early summer, and a higher than average incidence of new cancer diagnoses in the autumn. Whether patients will now present with later disease and cancer mortality will be increased because of this, that is a genuine concern that has been raised, that a delay in diagnosis we know can impact on mortality down the line. Whether the delay is significant enough to really increase mortality in breast cancer, which is a highly curable condition in many patients, I think only time will tell. But I expect we will see later stages of the disease presenting more than we would have expected on a seasonal basis. But we'll just have to wait and see.